Every floor nurse knows this scenario. Your new admit rolls up from the ER. The IV's right in the bend of the arm, and the pump just won't stop alarming. You silence it, check the line, and let out a little sigh. If everyone hates it up here on the floor, why do the ER and radiology keep using that exact spot? Well, let's break it down. There's actually solid science behind it. It's all about blood flow and speed. Think of the veins in your arm as a highway system leading to your heart. The veins in the antecubital fossa, that little bend in your elbow, are like the superhighway. They're bigger, they're closer to central circulation, and blood flows through them at a whopping 150 to 200 milliliters per minute. Now, compare that to the veins in your forearm, which are more like a scenic country road, moving blood at a slower 80 to 120 milliliters per minute. That extra flow is critical in certain situations. It helps deliver emergency fluids and medications faster. For radiology, it means they can push high-pressure contrast dye for CT scans more effectively. A faster flow also dilutes that contrast dye very quickly, which lowers the risk of serious tissue damage if a small leak or extravasation happens. So for the ER, where every second counts, and for radiology, where high-pressure contrast needs strong, fast-flowing veins, the antecubital area is the express lane straight to the heart. It's the right choice for that specific moment. But once that patient gets admitted to the floor, that perfect IV becomes your daily headache. It sits right across a major joint, the elbow. So every time your patient tries to eat, adjust their bed, or just get up to use the bathroom, trouble starts. You get occlusion alarms over and over. The constant bending and straightening can cause infiltrations, where the fluid leaks into the surrounding tissue. It can also irritate the vein itself. And most of all, you have a frustrated patient who can't comfortably bend their arm. It's a constant battle. The line that works so beautifully in the fast-paced, high-stakes environment of the ER just doesn't fit the slower, longer-term needs of inpatient care. Now, here's something you might find surprising, especially when we talk about leaks. What about the risk of compartment syndrome? It's a serious condition where swelling and pressure in a confined space, like a muscle compartment, cut off blood flow. You might think a big leak in the antecubital fossa would be a disaster. But the AC area actually has a lower risk of compartment syndrome compared to the forearm or hand. That's because the antecubital fossa doesn't have as many tight, restrictive muscle compartments. If contrast or fluid leaks there, it has more room to spread out without building up dangerous pressure. The forearm and hand, on the other hand, are packed with multiple muscle compartments wrapped tightly in fascia. If fluid gets trapped in one of those, pressure can build up dangerously fast. That's why extravasations in the hand or forearm are often more likely to lead to compartment syndrome. So what's the smart transition plan? It's all about teamwork and timing. Once the CT scan is done, the emergency is over, and your patient is stable, it's best practice to move that IV. Explain to your patient why you're doing it, then skillfully remove the AC line and start a new one in the forearm. A forearm IV is more stable, it's far more comfortable for the patient. And it's a safer spot for ongoing infusions or routine antibiotics that they'll be getting over the next few days. The patient can now move freely, and you can finally have some peace from that beeping pump. So let's do a quick recap. For the antecubital fossa, you've got high blood flow, lower compartment syndrome risk, but poor long-term stability and comfort. It's perfect for ER access and CT contrast. For the forearm, you have slower blood flow and a higher compartment syndrome risk if a leak occurs, but it offers excellent stability and comfort for long-term use, making it ideal for inpatient therapy. The next time your patient rolls in with an IV in the bend of their arm, remember the why. ER and radiology choose it for speed and safety during a critical window. But once that crisis is over, it's the floor nurse's turn to take over, prioritizing long-term comfort and stability. It's all about different settings and different priorities, but it's all part of the same patient-centered teamwork. Thanks for watching and for supporting my channel. Let us teach each other. If you found this helpful, give us a like, and don't forget to subscribe for more nursing insights.